disorders to cover in a very short amount of time. If any of you want more extensive information on any of these mental disorders that I'm going over, feel free to come and talk to me after breaks. We have little packets that we can send out that gives a little bit more information on these disorders, or I can give you resources and you can do your own research. Research is very imperative to any mental health disorder that you are going to encounter or that you have any questions on. Majority of my information came from the DSM because I had to take a test. All right, I know, the scary test. So the agenda is categorizing common mental health disorders. We're gonna play a game, because I love games. It's gonna be called Name That Disorder, so pay attention because you might get snacks. Then we're gonna go to how to put this all together, and then if we have time, we will answer questions. If not, come see us after and we'll answer any questions that you have. All right, so the first one I'm gonna cover is schizophrenia. So I sent out a lot of surveys between mental health first responders and first responders such as police officers, EMTs, school social workers, and any other mental health or first responder that I could think of. The first one was schizophrenia. So schizophrenia is what we know is like a thought disorder. It has a lot of disorganized thinking, which, as you can see up here, is speech, feelings of disorganization. So this is where someone's gonna talk and it's not gonna make a lot of sense. They're gonna jump from one topic to the next topic, and it's gonna be really hard to follow. Hallucinations. This is auditory or visual hallucinations. Most common is the sixth sense, I see dead people, or I hear voices. Now, sometimes when this is present in children are more likely to say that they're gonna see shadows, or it's gonna be dark shadows, light shadows, and it can also lead to a lot of religious type things. So I see angels, I see demons, any type of those. Now, not necessarily those are hallucinations. You have to check your religious backgrounds and see what they believe in and go from there. Next is delusions. This is what you think, okay? Delusions are paranoid thinking. Typically the government is out to get us, or I've been abducted by aliens. If you believe in aliens, I am not saying you are delusional. I'm just saying this is common. Do not come for me, please. Okay. Next we go is catatonia. So catatonia is that stereotypical response that you see in movies all the time where someone just sits like this. They don't move, they don't speak, they are not here. Now, or they could speak very slowly. They don't have that connection to have a very equal or common conversation that we are having now. The next one. So just because someone has psychosis or those psychotic features we went over, which is hallucinations, delusions, or some type of catatonia, does not mean they have schizophrenia or a thought disorder. It can be substance induced. Medications that we'll cover medications that can induce psychosis, but what does substance-induced psychosis look like? So it causes distress and impairment in social, cognitive, and behavioral levels. They cannot interact the same way. It's very, very, very obvious that something is wrong with them. It can have lasting effects even after someone becomes sober. So I had a client who used 900 milligrams of marijuana gummies for 6 months, took 6 months to detox, and they still had psychotic features afterwards. Sometimes when you overdose on a substance use, that a lasting effect has already done damage to the brain. Then you can follow this up with like a history, physical science, laboratory findings. Obviously, make sure the doctor is, or a psychologist, whoever is involved in that patient's care, is actively going through all the medical necessities that it is to watch whatever is happening. And as we said, it can have immediate and develop over prolonged use. It doesn't have to be instant. It can be multiple overdoses. It can be multiple years of prolonged use that can induce some of these symptoms. And those symptoms are the delusional thinking, the hallucinations, and the disorganized speech. So some of these substances that will cause substance-induced psychosis, any of them. In children, we are seeing marijuana or cannabis is affecting children a lot more because kids are starting to get marijuana off the streets. And they are being laced with all of these. not alcohol, but they are combining alcohol and marijuana use in children at a very alarming rate. Adults, all of them, they're lacing it. Just because it's legal doesn't mean that it's safe. So next we're going to go to intellectual disabilities. So intellectual disabilities is under the language, reading, writing, math, reasoning, and knowledge. So that this is going to look like dyslexia, stutters, which I have one, as you can tell, and then also going to go to speech impediments. Sometimes it looks like they can't do math and they're having difficulties with math, or simple word problems are going to look difficult. Social domains is they can have a lack of empathy or too much empathy. Their social judgments, maybe they're making friends with people they don't need to be friends with, or maybe they're staying in friendships that are very unhealthy for them. They're not going to know how to regulate their own skills or regulate their own emotions very well. And then it goes into the practical domain. This is how, can they care for themselves? Can they keep a job? Can they have a complicated job? Does it need to be more simplistic? And organization and work. So maybe sometimes they have to slow down. Maybe they need to take a few more steps in order to achieve a goal. One of the most common ones is autism. Now, I am not an expert in autism, but these are the most common things that I see when working with people with autism. I know from my own personal experience, I have to watch body language cues very, very often and very hard, because I can give the wrong cue and it could set them off. If my tone's in the wrong spot, I can also set them off. So it's very important that whenever you're having a conversation with someone with autism at any level, it's in a very calm tone voice. And it's very simple conversations. Sometimes they can't understand if you're having big, elaborate conversations with them, so it's really nice to break it down. The other thing is stemming. A lot of people with autism are going to stem. Some people are like, stop that, we don't need them to stem. Let them stem. It helps regulate themselves, it helps calm them down, and it helps know that they are safe and they need to do that. Unless they're getting violent, then of course, take measures to make sure that you're safe and your client is safe as well. Okay, the next order is bipolar 1 versus bipolar 2. Again, this is the very brief overview of a very complicated disorder, so please look into this more. So bipolar 1 is probably the most common bipolar that you will encounter than bipolar 2. Bipolar 1 has one episode at least of mania. What is mania, you ask? Great question, everybody. I will tell you what mania is. Mania is when you have super, super high highs. So it can be erratic, they can be very mood swings. So it's very up, very down. Like, have anyone seen like when Robin Williams goes? Yes, that is that. So they tend to be very, I want to say impulsive, because when they will go and they will act out of character. That can be look very sexually, or that can be, I'm going to buy everything in the store and I can afford to do so. That's just a main sign for it. They will lack of sleep, talk very fast, and have a very grandiose personality. Bipolar 2, they will have that mania, but it will drop to very severe depressive episodes. So they may not get out of bed, they will have hopelessness, they won't think that they have any meaning in life, and it will go very sporadic. All right, I was very surprised to see anxiety and depression on my questionnaires, but I think the most common ones that people had difficulty differentiating between anxiety and depression is anxiety is more fear-based. It is the fear of the unknown, it is the fear of, am I good enough? It is the fear of being judged. When you have depression, is more hopelessness. Depression is more sadness, depression is more loss of interest in everything. That's why some people won't get out of bed, or some people won't take the shower, because they just don't have the motivation to do so. Okay, again, ADHD and ODD were on my list, but it was sometimes it's very common to deal with those in kids. So the only difference that I'm going to say between ADHD and ODD is ADHD is more like emotional dysregulation. So a lot of the times, kids or adults are gonna act out because they don't understand something. And it's not gonna be as violent as when you have ODD. ODD is like that vindictive, whenever you look at someone and you tell them not to do it, and they break the vase anyway. That's ODD, that's a little vindictive. And ODD is more anger-based. So whenever they lose control, it's gonna be more violent tendencies than what ADHD is. Okay, the next one is PTSD. PTSD is very complex. This little overview is not going to be exactly what you need to look at. Okay, so PTSD, the main common symptoms of PTSD that you're gonna see in adults and in children are the re-experiencing symptoms, which you're gonna have that intrusive thoughts, bad nightmares, an intense emotional response to what their trigger is or anything related to that trigger. Then you're gonna have avoidance and numbing symptoms, which is they're gonna avoid anything that has that trigger. And they're gonna be a loss of interest in activity. They can isolate and be very hard on themselves. The next one is difficulty sleeping, hypervigilant, not wanting to be in a crowd, and not wanting to be able to where they can't see the whole entire room. And then the last one is personality disorders. The most common personality disorder that I had on these sheets was borderline personality disorder. BPD is very complex. It has a lot of trauma that is tied to borderline personality disorder. So it is the instability of interpersonal relationships. So they have a very favorite person. That person is their favorite person. It is the greatest person on the face of the planet. And then they do one wrong thing, and then they're like, nope, I hate that person. We no longer want to be around that person. That person is the world's worst enemy. And it goes very quickly. BPD also can have very impulsive behavior. They will be in relationships constantly because they do not like to be alone. They don't like to be alone with themselves. They seek validation from anyone and anything. Okay, do we have any questions so far? No? Fantastic, it's game time. We're gonna play Name That Disorder. It's so exciting. Okay, so what we're gonna do is, I'm gonna play some clips, and then we're gonna have A, B, and C, and you're going to pick one. And if you get it right, guess what you get? Candy! It's very exciting. We have bags of candy! Okay, so we're gonna take at least a minute or two to get there, and then we'll go on with the presentation. So, here we go. If it plays.
It's not.
Okay, what do we think that is? No, don't play. Do we think it's delusions? Do we think it's borderline personality disorder? Or do we think it's drug-induced hallucinations? Converse!
That's my answer. C. C. Tell me if I'm right. Tell me if we're right. Or Bob texted me.
Are you good?
Crisis. No, just kidding. 911.
Stop us saying that. We saw it.
Give me a brave soul to raise their hand and see what they think. Who wants to tell me? I know this table does too. Okay, back there. Yes. What do you think it is?
C.
C? Possibly. Could be a possibility. I forgot. These questions have two answers. So yes, if someone could go get candy to the table over there. Woo. Okay. Who else had a hand? Yes, I see you.
We said possibly schizophrenia with delusions because he's fearing that someone is behind.
I love that. They can also get candy. All right, one more table. Anybody? Anybody? Yeah.
We're going to see.
Absolutely. It is A and C. Well done. Candy, candy, candy. John, when am I playing the whole clip or how? Commercial break. This is also a little bit disturbing, so just a heads up.
I have so many good memories from
Shut the fuck up. Yeah, you better believe it. I work for the public. You want to try to look at other women? No. You ain't going to look at other women. And you ain't going to tell me you're looking at other women. Yeah, I know I sold the child. I already know. I'm not going to say nothing if you don't say nothing to try to cause a commotion. Because he's the fucking problem. You want to shut Oh, really? Think I'll put you right now. You shut the fuck up. Shut the fuck up. No. Oh, you gonna come up? Hand up. You're assaulting me, man. Oh, assaulting you? I know. Yeah, I'm assaulting you? I'm gonna get my purse. Are you okay? Do you want to say I'm assaulting you? You Memo? Yeah. I'm coming, I'm going over there. You're going to be charged with assault. Fine, whatever.
Okay, see that clip. Now,
Protect your family.
we're gonna ask you, what do you think that happened in that clip? Do we think they have anxiety? Do we think they have ODD? Or do we think they have borderline? Converse! Brave enough to raise your hand and tell me what we think this person has. Yes, table in the back. What you got? Yeah, you.
Borderline.
Yes, well done.
Except everybody else has anxiety.
Yeah, I mean, I wasn't ready to diagnose the whole entire plane, but yes, ma'am, everyone has anxiety. So actually, I guess that all three answers are right, apparently. Woo! Okay, yes, you. Yes, ma'am. Definitely. So ODD, when it's diagnosed in kids, it can grow up to be conduct disorder, which conduct disorder is more of violence towards others, it's damage of property, and it can look like that, which does not care who's in the room, does not care what's happening, I'm going to do what I want, and I'm going to be vindictive. So yes, ODD, which develops into conduct disorder, absolutely. Fantastic. Well done! You guys are so smart. Okay, everyone does, and I hope everyone's just not raising their hands. Yes, okay. So let's go into what trauma is.
When something traumatic happens that is so big and so painful, you just can't bear to look at it. The only thing you can do is push it down. This way, no one can see it, and as long as you don't think about it, it's gone. So you carry on with life, and it takes everything you have to hold it under the surface. But then, one small thing happens that triggers the memory, and everything comes to the surface, and it's too much pain all at once. So,
And that is trauma. And after that, I'm going to hand it off to my co-presenter, John. Yay.
when something traumatic
So I'm not going to walk around like Rachel. I don't have that much energy left. Yes, we're therapists right at this early in the morning. We've probably already had a few of those in our offices. So hey, you know, kind of moving along. What do we do with all of this? Right? Those clips, you could probably answer any one of those answers for the symptoms that you saw. right? But you've got to use something. And what we're doing here this morning is introducing you to something that we hope to be able to do with our local first responders, police, firefighters, EMS, even ER nurses for that matter. If you've ever been in an ER at a full moon, right, at midnight, it's not a pretty place sometimes. But what we want to do is give them a quick way to approach a mental health crisis, right? Something like the woman on the plane, something like the gentleman who was either drug-addled or just afraid of whatever was in the other room, right? You need a quick way to approach that situation and be able to handle it. And that's what we're hoping to do, at least to introduce you to today. So putting it all together, we have one approach called Make Safe, Make Sense, Make Right. And the three terms together come from an author and consultant, Dean Malpass. Right? Dean lives in Yorkshire, England. We've talked a little bit. He gave me permission to use his material, this book. And this is one of his concepts. It's a step-by-step guide. Step-by-step guide for first responders. The interesting thing is it's useful for everyone. I'll show you what I mean. A proactive assessment to triage and then transfer individuals to mental health professionals that facilitates three things: a safer environment for the responder and the person in duress, a sensible time and place to do the most supportive good we can do, and the best resource approach to reduce symptoms and encourage better functioning. So what do we do with this? Make a situation safe. So we want to prioritize safety under all circumstances. For those who are in duress, for the responder, either the officer, the firefighter, or one of you, right, in the hallway or at work or something, somebody's going off, what do? We make the situation safe as we can, and also for the bystanders. There's 5 parts to make it safe, and I'll try to go through it for you. I won't belabor how we do these all, but you will be able to see it, and if you need or want further information, you can always follow up. You assess the scene, what's happening. So when you're the first one on the scene, you've got to evaluate the risks and hazards. This includes, are there any weapons? Some of you may not be in situations where weapons could be present, but you never know. Assessing the individual's behavior for signs of aggression, like the woman on the plane. Evaluating the presence for bystanders, right? Who's near? Who's at risk? Children, babies, other people who are vulnerable, disabled. Next, call for backup. Is there anybody else you can enlist to help you? Right? Can somebody else help support you, watch your back, give you more situational awareness, or maybe they even have handled a crisis like that before? Establish a perimeter. I know this sounds military or very law enforcement type language, but still, if you can minimize the situation to the lowest, smallest possible area you can get, that's how you make the most good and the most safe out of the situation. To the extent it can be done, you can cordon off bystanders by using that person, hopefully, that's assisting you. Communication and de-escalation. Many of you already know these techniques. You know how important they are, and they're no less important in a situation where you have an uncontrolled mental health crisis. So effective communication is the key. Keep calm. Speak in a normal tone of voice, right? Kind of just like what I'm doing up here. Just talking to a bunch of people I just met. How are you, right? No problem. Continuing the communication, de-escalation, establish rapport, right? Try to get the person to see you, to hear you. Gain some trust. Maybe you can talk them down. but you're focusing on keeping people safe during this communication process. And the last part there under the communication, listening. All of you mental health professionals, social workers, whomever else is represented in here probably understand that sometimes listening is more important than speaking. Hear what's happening. That'll get you some insight. The use of force. This is controversial, both in the UK and the United States, according to Dean, but it is controversial. So if it comes to it, God forbid, people turn violent, use the situation in accordance with your training and your authority. If you don't know what to do, you don't have the authority to do something, escape, evade, hide, right? It's a good protocol. If you understand passive restraint and you have somebody helping you, this is a good time to employ that. Again, I'm not going into some of the details of this. This is for material for a follow-up conversation. So what do? We're making sense of something. For this part of it, the first part of our presentation that Rachel was giving you, this is information that a lot of first responders, professional first responders, don't have. Those of us who are thrust into a situation, who have some of this background, can probably make an on-the-spot diagnosis, or at least one that's good enough to handle the situation. So we take that information and we help first responders understand it and apply it by making sense of the situation. So when we do that, there's another category, another framework that you can use, and this is taught among a lot of police departments, fire departments, EMS, various places in the United States and overseas. Delusion, disorder, and trauma, DDT. So it's just a framework to approach symptoms, right? What do I do? What am I seeing and what do I do with it? So the comprehensive framework, it's a therapeutic approach that provides immediate and effective support. DDT, 3 primary areas: delusions, right? We talked about false beliefs, are resistant to reason and contrary to reality. Disorder, managing symptoms of psychological disorders such as anxiety, depression, PTSD, and trauma, which could present as any of those at any point in time. So we're making sense using DDT. Delusions, right? You're unlikely to be able to challenge the delusion. You can try. You can argue with somebody that says the aliens are coming, I need to wear my tinfoil hat. Those of you with tinfoil hats, it's okay. Right? I'm going to go with you on that journey. But I'm unlikely going to be able to tell you that's not what's happening. You just want to understand that. We can give you more at another time. Disorders, psychotic symptoms, hallucinations, delusions, disorganized thinking. We saw what that can look like on one of those clips. Manic symptoms, elevated mood, increased energy, impulsivity, and grandiosity. Depressive symptoms, persistent sadness, fatigue, changes in appetite, sleep. Sometimes these types of symptoms are only going to come to you in a situation where somebody else knows the person in crisis, right? The person in crisis is not going to be able to say, oh, I've been down for a little while. No. Somebody else will say, hey, this guy's on medication, right? He's seeing a therapist, and you get some additional information to use to move forward. Anxious symptoms, you can certainly see these: excessive worry, restlessness, irritability, rapid heartbeat, sweating. You can't hear my heartbeat. It is beating a little more rapidly, and I don't sweat under these circumstances, so I'm not a good example. Trauma. So trauma comes from all kinds of early childhood or even later experiences where you're fearing for your life. In a situation where there is trauma and somebody is experiencing a mental health crisis, you have the information you need under those circumstances. You might even be affected yourself. That's part of our larger presentation. But acute stress reactions are some things that you would see under those circumstances. And they certainly do exacerbate other mental health conditions that a person might have. So trauma is just going to make everything worse. We're still making sense using DDT. This is the trauma part. Sensitive trauma-informed communication techniques, just understanding how to talk to somebody is basically what we're saying. And then finally, collaboration with trauma-informed service providers, people like us, people like Lori over there at Alliance. She focuses on trauma. So a little bit more, some of the things you're going to see under the symptoms of trauma: hyperarousal, an aggravated startle response, for instance, or difficulty concentrating; avoidance of trauma reminders; the emotional numbing and social withdrawal is probably what you're going to see in a situation like that; and re-experiencing. You're going to know somebody's having a flashback or re-experience something of an emotional crisis when they're saying something about it. A lot of times you'll see this in vets, other individuals who've been in some life-threatening situations over and over again. You'll usually know what's happening. So a final element of trauma: dissociation, right? Where the person is just not connected. And they might even be able to tell you, this doesn't feel real. I'm outside my body, I'm just observing. So how do we make it right? The third part of make safe, make sense, make right is the collaboration piece. Right? That's where we all work together with police, fire, EMS, therapists, social workers, agencies. That's where we're coordinating to make the training possible so that we can all make right. It's also the culmination of everything we've been talking about this morning. How do we make it right? The multi-agency collaboration. And that's why we're here. Alliance Counseling, it's one of the things that we do. We can come to you. We're committed to going to our local and regional law enforcement, firefighters, dispatchers, EMS, corrections. We took a survey, Rachel mentioned earlier a couple of times, took a survey from most of these departments throughout our region. And these are some of the things that came out of that. They are very reluctant to talk about this. This is a very ripe field to help our community first responders and anyone else who finds themselves in a situation like on that plane. What do I do if my friend is freaking out because of something in the other room that's not there? What do I do? You can use the same approach. And so we'll train anybody who would like on this DDT framework and the make safe, make sense, make right approach. And we also work with our first responders in the counseling setting. So we'll work with their EAPs, they'll come in, we're confidential. We've got many, many first responders, so that's already happening. You want to know more? Here you go. That's our information. We have some cards in the back. We also have some sign-in sheets. If you go sign in and you put some information where we can contact you, or you can contact us on that sheet, we might just have a prize. So stay tuned and we'll let you know when to come back and claim your t-shirts. References if you need them. Thank you all so much. Appreciate it.